And then we're supposed to also be talking about periapical abscesses. There's no way in 30 minutes I'm getting to both. So next week, and that kind of prompts me to think about next week as well, because that's Veterans Day. So we lose a class day, but there's still content. So what I'm doing, I'm not allowed to assign work on a holiday. And so I can't, this is technically not going to be for the class, but I'm assigning it for lab. So there are going to be recorded lectures that you just have to listen to. There's just no way of like getting around it. There's content, we have to go through it. So it's going to be under the lab section instead of class. So just be aware of that. They're easy. They're not like in depth. I don't even test extensively on them, but they are on the mini exam. So you still need to listen to them and go over it. But on the mini exam, I far more focus on this content, the abnormalities, the periapical abscesses. That's a lot more. And dental materials is also on the mini exam, and then some of the other specialty imaging, such as the content that will be recorded. So in all likelihood, I'm going to record periodontal abscesses, which is a shorter PowerPoint, and then the content for next week as well. So just heads up for that. So abnormalities. So we're going to look at different abnormalities that can include teeth number abnormalities, shape, structure, the way a tooth is developed. We're going to identify, this objective is probably for the other PowerPoint. So I don't know that we're going to get to the lesions, the cysts, and the periapical abscesses. So we'll just stick to the abnormalities. Is anybody else's like internet acting okay? Because I'm like, like I'm about ready to throw my computer. I can't even advance my slide. I don't know if there's, when it happens like this, very often time it's like university wide and they're just sitting there going, oh, they can't usually do much. So if somebody wants to go check in with them, I would not mind that, but I doubt he can fix it. It's probably a server thing is what I'm assuming. But thank you for, I'm like totally stuck. My slide won't even advance. Oh my goodness. Do you want to? Is yours advancing? Let me see if I just also re. You want to use my computer? Thank you so much, Ellie. Kate just offered. So, okay. Because she's got two things going here. So this is good. Okay. So the categories are the numbers, the size, shape, structure, eruption, and miscellaneous. So there's a lot of terms in this PowerPoint. This PowerPoint is an easier one because it's like pictures and terms. So it's not very hard content to like wrap your mind around. So anodontia is the absence of teeth. Hypodontia or oligodontia is partial absence of teeth. So like less than hyper is more, hypo is less. So missing some teeth, but not all. Most common teeth, there's certain teeth in the mouth that when somebody has a genetic, like they're missing something because of a genetic reason, a lot of times it falls under the third molars, followed by the maxillary lateral incisors. So sometimes those can be congenitally missing is the way we term that. And then also the premolars, maybe less so, but the premolars can also be affected. So it kind of goes in sort of that order. Like my husband has one wisdom tooth, and so it's just like, it's normal for like people to not always have all four. Sometimes they have none, sometimes they have two, sometimes they have all four. If premolars are missing, oftentimes you end up with an ankylosed primary tooth. So if a premolar is missing, you have those baby molars in place of the primary teeth, and oftentimes they get ankylosed or like fused to the bone. So the relationship between the tooth and the bone is it's harder for it to be extracted, which is a good thing because most people want to hang on to that baby tooth as long as they possibly can. So this is just some images here. So you can see that this is something we might see clinically, wondering where are those teeth? Why aren't they coming in? And then when we take panos, when you go to the next image, you can say, oh, they're not there. Now those lateral or mandibular central incisors, those are not like the most common ones to be congenitally missing, but it would appear, at least that's the story that these images are trying to tell us, that those didn't develop on this patient. So here's another picture of a baby molar, and you can see below it there is no permanent premolar. So that next slide 7 shows you can see, unless it's way down there, there's nothing coming up to, and therefore sometimes they don't get resorption of the roots, because a lot of times it's that pushing up of the next tooth that resorbs the roots of the baby teeth. And so sometimes those roots don't get resorbed, which is a good thing because they're much shorter. They usually they have a shorter prognosis for staying in the mouth, but if the person cares for the tooth really well and everything goes well, the tooth can stay in there. So there's just another example of it there in slide number 8. So then we have defect in tooth numbers. So that is referred to as hyperdontia, so one or more extra teeth. And then some specific names for that would be supernumerary. So that can be like you have a supernumerary tooth, say you have an extra third molar. So you have like a little baby third molar behind the normal size third molar. So that'd be a supernumerary. Sometimes people have an extra premolar or something like that. So those are supernumerary. But very specifically, if a tooth is, if there's like an odd little small shaped tooth in between 8 and 9, specifically that's called a maxillary mesiodens. Oh, I think my computer might have decided to cooperate. Let's see, I'm just gonna advance it here too, so so that the recording shows this. So it's only a maxillary mesioden if it's between the 8 and 9, basically. So here's an image of an extra premolar. You can see there's the 2 permanent premolars, and then down in the bone there is an extra one. And then this is what it might look like intraorally. There's a intraoral picture of 4 premolars there on the lower right. So one thing, there's a term coming up here, and one thing you're going to have to kind of think about to help you determine between these two terms, between gemination and if it's fused, if teeth are fused, or if there's extra teeth, is you have to kind of think, let me count the teeth and see what's there. So when we go through these teeth on the mandible, we see the 2 canines, and then in between, we see that there's 1, 2, 3, 4, 5 teeth instead of 4. And so this will become a little bit more helpful when we're learning the difference between fusion and gemination. Here's another example of a supernumerary tooth between the roots there. Bunch of teeth down there. There can be tumors called odontomas, and they can have be partial tooth buds, like a whole bunch of them, and it forms kind of like a tumor, like partially developed teeth. There's another supernumerary tooth in between the canine and the lateral. And then there's a picture of an actual mesioden. So on the exam, don't get confused if it's asking specifically about between 8 and 9. It's a mesioden, not just a supernumerary. So that's a specification. And then there's an intraoral image of it. There's a little mini tooth back behind that molar. So all kinds of things you'll see in people's mouths. There's a little tiny one between looks like the canine and the lateral. Okay, so then the next category is defect in size. So macrodontia would be larger teeth than normal. Microdontia would be smaller. Very oftentimes our supernumerary teeth potentially are microdontia. They're not always the normal size as the ones that come in. And an example of that would be a peg lateral. So here's that lateral looks much larger. It almost looks like the same width as the central. So that's a macrodontia tooth on slide 21. And then on slide 22, you can see the peg lateral. And so those are not super duper common, but like pretty common. And then there can be teeth in between, like they could be, not quite pegs, but they seem a little bit smaller. Alterations in tooth shape is another one, and this kind of goes into some of this fusion and gemination and just some abnormalities in the formation. So as the tooth forms, the shape gets changed. So fusion is the union of two adjacent tooth buds by dentin and or enamel. So for fusion, you have two independent tooth buds. For gemination, it's an aborted attempt by a single tooth bud to divide. So it was one tooth bud that was trying to divide, didn't work out so well. And so then it just kind of, makes it look a little bit abnormal. Concrescence is another term, and that's the union of just the roots. So if two teeth are sort of fused around the root surface, the cementum, that's concrescence. So these are all just pretty, you want to know the image, like what it looks like, and we'll come to those in a second, but you also want to know that just the definition or the terminology. So a tip for knowing the difference, and this is like what I was saying earlier, the tip for knowing the difference between fusion and gemination when you're looking at an X-ray or when you're looking clinically in somebody's mouth is to count the teeth. So if there's too many teeth, then that's gemination. And if there's not enough teeth, that's fusion. So if it looks like and sometimes it's not that there's actually more teeth, it's that it might look like there's more teeth. So it's that one tooth trying to divide. So it kind of gives the appearance of two teeth, but really it's just one tooth bud, but then it makes it look like there's extra teeth. Whereas fusion might look like just one big tooth, but really when you get the X-ray, you can see that it's two teeth fused together. So it can be a little bit tricky. So on slide 24, this is an example of if we were to see where the canine is. So we have a canine here on it's the left canine, but it's our right side of the screen. And then the other canine is out of the picture on the patient's right. And so there's only 3 laterals there. So if we go back up here to slide 23, if there's not enough teeth, there's only 3 laterals, but one looks really big, then it's fusion. Yeah. And then here's an example of on slide 25 where that tooth, you could see it it's like one tooth that was trying to divide. So that's gemination. And so again, here in this, the intraoral picture, you can see the canine and there's 3 laterals, but one looks twice as big. So that's fusion. And then here it looks like the 8 and 9 are trying to divide. So that's gemination. Sometimes it's more obvious. Sometimes it's a little harder to tell. It's probably harder to tell in a mixed dentition like this here, but you can still kind of see that it looks like one tooth trying to break in 2. So there's gemination again on slide number 28. Slide 29, it was a baby tooth that had tried to divide into 2. So that's gemination. Yeah.
If it's a baby tooth, there's a tooth, does it resemble the same,
It's like the same issue.
yeah.
No, not necessarily. Yeah, they can look, they in general do look pretty different, like from baby teeth to adult teeth. But so if they have an issue like gemination or fusion in a baby tooth, they might not have it in their permanent, or they might end up having something in their permanent and have not had any issues in their baby teeth. So yeah, that doesn't always end up the same. It's a good question. Fusion, so the next one, so slide number 30 is fusion, the union of 2 adjacent teeth. So you can tell that by counting those teeth. So here's a picture of extracted teeth that's concrescence, because you can see the roots are kind of intertwined with each other. And then that's just an X-ray of the teeth laying on the table, but it might, look something. It would look like they're overlapped. You might not always be able to tell that they're literally fused together, unless you do some kind of another imaging like a CBCT or something. But sometimes you can tell. Okay, so here's some more alterations in tooth shape. So these are all focused more on the roots, I believe. So dilaceration, we've seen that already in Dexter. Like Dexter has dilacerated roots and it's like a curvy, wiggly, swoopy root. And especially at the end, when the end kind of swoops off. So dilaceration, a bent tooth, usually as a result of trauma during formation and or eruption. Then we have torodontism. So tora comes from the word bull, and the reason they say it is because the pulp chamber has a very strange look, and it almost looks like the horns of a bull on the bottom part of the root chamber, the pulp chamber. And so we'll look at it in a picture, and that'll help you see it better. But it refers to teeth that have abnormally large pulp chambers and shortened roots. So that's torodontism. And then supernumerary roots, more roots than you'd expect to see. So on a mandible, you'd expect two roots. If there was a third, that would be a supernumerary root. Sometimes are roots that only have like one root, if it's bifurcated, that's supernumerary. So dilaceration, so there's an example on slide 34, kind of the wavy, curvy roots. That's dilaceration. There's another example of it, and you can see how that's a problem on slide 35. That's a major problem for a root canal because they perforated the apex toward the apex of that root instead of following the curvature. They just went straight and then they perforated the root. So that's really bad. That's not going to be a successful root canal. And then 36, that's just an odd looking little tooth, but there's some kind of an extra little bit of root there in between, or a couple little extra bits of root on that extracted tooth. So bifurcated roots on second premolars, this pano, it's kind of hard to see because it's a pano and it's small, but if we were able to zoom in, you could see these premolars have bifurcated roots on the second premolar. Supernumerary root on the mandibular molar. You can see a third root in between those mandibular mesial and distal roots. And then bifurcation on this canine, I guess that's a canine picture. Slide number 39 is an example of torodontism. So you see how that the root, instead of it coming to a tapered apex, it is like blunted. And so the bottom part of it kind of almost looks the same as the top. So that's that where they got the word bull, because it kind of looks like a bull, horns, I guess, on the bottom, but it's just more boxy. So that's torodontism. Let's see. Oh, I think there's a couple things going on here, but the canine specifically is bifurcated. It's kind of hard to see, but it's bifurcated on the roots of the canine on slide 40. And then 41, alteration in tooth shape. We have more. So there's enamel pearls. That is a small round radiopacity seen on the cervical portion of a root. It's like some enamel that migrated down and is actually on the root surface. When you feel it, you might scale it and think it's calculus at first, but it's really, really, really hard and it won't budge. So you're just going to kind of bop over it, and you won't be able to smooth it. A pulp stone is inside of the tooth. So a pulp stone is not on the enamel pearl is on the outside. If there was bone loss, if the bone had gone down, you could feel it. But not necessarily if it's embedded in bone, you're not going to feel it. But pulp stone is inside the tooth. So those are different locations. And then we have dens in dente. It's a result of an infolding of the tooth's surface before it calcifies, most often seen in permanent lateral incisors. 1 to 5% of the population can occur bilaterally. So the enamel and everything, before everything hardens and calcifies, while it's forming, it all kind of infolds on each other. So it gives it a little bit of a different look. And then on the X-ray, you see more radiopacity in the center of the tooth. So that's dens in dente. And then I always say this word wrong. I always say Leonge's premolar, but I don't even know if that's right. So Leonge's premolar results in the outfolding of the enamel during formation. So it kind of has almost like this extra pokey cusp in the center of it. and it's calcified, has enamel on it, but it kind of looks like extra cusps in the middle of a premolar. And oftentimes these are affected by the premolars. So on slide 42, that's an example of an enamel pearl in the furcation. On slide 43, there's x-rays where you can see enamel pearls. And and they have lost bone around the enamel pearl. So you would likely be able to feel that or scale that. And at first you would probably think it was calculus. 44 is an x-ray of enamel pearl in the furcation of the first premolar, but it would be hard to determine whether or not that was a stone in the pulp chamber or if it was enamel pearl. So if there's all bone up around it and you can't access it, you can kind of guess what you think it is, but you wouldn't necessarily have a definitive diagnosis. Here's another pulp stone. So this one is a little bit easier to see that it's actually residing in the pulp chamber on 45. And then on 46, you can't really see it as well here, but there's going to be an x-ray that goes along with it. But the lateral has the dens and dentae. So you can see that it's a little bit misshapen. And there's also a fistula going along with it. See the little gum pimple? Sometimes that's what patients refer to it as, a gum pimple, but the technical term is fistula. And there's some kind of infection that's gone on around the tooth, and the infection is trying to find a path of least resistance to release pressure. And so it makes a tunnel and tunnels its way out to the outside world. And then you get this like little gum pimple to release the pus that's building up. So that's what that is a fistula. And you can see when you look at the slide 47, that there's a periapical abscess around that lateral that has the dens and dentae. So maybe they got decay, because the folds are probably more extreme, probably harder to clean. Maybe they got some decay in there and it just wasn't treated, and then it became an abscess pretty quickly. So that might have been what happened there. On slide 48, a clinical image of the dens and dentae. You can see it just has, especially from the lingual or the occlusal perspective, you can see it has just a really different look to it. And then the Leonges premolar, you can see it kind of is like a little pokey, sticky outy, extra funny look and cusp there on the occlusal surface of the premolars. Okay, slide number 50, alteration in tooth structure. The root resorption, there can be, and this can be this is totally something a dentist diagnosis. Like you can notice, you can take the x-rays and you can be like, ooh, something's going on there. And then you can kind of warn the dentist, like, I think there's something going on with the roots, but the dentist is the one that's going to diagnose this. So it's not that you have to worry about it, but it can be kind of weird looking on an x-ray. So external root resorption caused by chronic periapical or periodontal infection, pressure from a tumor or a cyst, rapid orthodontic movement, or like an unknown reason. It can literally, I've seen it happen in healthy mouths for like no good understood reason. So sometimes this root resorption happens. So it can be external or it can be internal. Trauma for internal can be trauma, exposure to heat or chemicals, or bacterial invasion of the pulp. I think you learn more about it in oral pathology over the summer, and she might go into a little bit more depth about it. But it's one of those things where sometimes trauma can be the trigger, but sometimes they're like baffled, like they are not sure why it's happening. Slide 51 is showing some example of some external root resorption, which that to me looks like it might have, that this can happen with orthodontic movement that's done inappropriately. So there can be blunting of the apex of the roots for orthodontic reasons. We wouldn't really know if that's why that happened there, but that's a possibility. For slide 52, internal root resorption has a different look because it makes the pulp chamber starts looking larger and shaped strangely. So you might say, well, how can I tell the difference between that and toroidontism? It's usually because toroidontism is usually in molars, and then not necessarily exclusively, but typically, and you might see this on any tooth, and it doesn't necessarily have that classic kind of spread out like bullhorn look. It could be just like rounder or oval, or there could be a different shape. And again, it's not necessarily for us to definitively diagnose, just to notice that something doesn't look right. Slide 53, pulpal sclerosis. Pulpal sclerosis is a diffuse calcification of the pulp chamber and the pulp canals commonly seen as people age. So as we age, our pulp chambers do shrink. We do build up more secondary dentin and things kind of shrink down. Older people in general tend to have a little bit less sensitivity to their teeth than younger people. When you're young, you just like cannot bite into ice cream, but when you're older, you kind of can a little bit. Doesn't bother you as much. Although that's not across the board, because some people do have cold sensitivity as they get older, so it's not like it's cut and dry, but in general, there is sometimes a shrinking of the pulp chamber, so there's less sensitivity there. 54, pulp canal obliteration. So pulp canal obliteration is the calcification or deposition of hard tissue within the pulp chamber. And we kind of like touched on that, but it can also be caused due to a number of things. You can see trauma, mechanical forces during ortho, attrition, abrasion. As the tooth is being assaulted slowly, it will build up a protective layer. And so if you are constantly grinding away at your tooth slowly, it's going to try and beef up that layer and protect itself and protect the pulp. And so that's part of that function. Abnormalities in eruption. So if teeth are impacted, some physical entities has prevented eruption, whether it's another tooth or what have you. That's why we like to take panos of like kids when they're like 6 to kind of see, okay, now we expect you to start, turning over some teeth, and let's see what's in your mouth. Let's see what you have, if you're missing anything, so we can see that developmental process. Some teeth are bony impacted. Most commonly, it's our third molars, but it could be like a canine. It could be a premolar. It could be other teeth too, but it's a lot of times we think of our wisdom teeth as being impacted. Soft tissue impaction is out of the bone, but it's covered in tissue. So we even see that on our Dexter, where it's like it's popped through the bone, but if Dexter had tissue, it would be covered. The one that we like, the nice Dexter, that has that situation going on. Transposition, a tooth erupts in an abnormal position. So if all of a sudden a lateral or a canine comes in where the lateral is, that's transposition. So sometimes teeth go in the wrong place. So here you can see this is an impaction on 56. And so sometimes the orthodontist has to like pull those teeth down. They put a bracket on them and they pull them down and guide them out. Here's another bony impaction on 57, the piano. There's a soft tissue impaction. It's kind of hung up on the distal portion on slide 58. It's kind of hung up on the distal portion of the molar. It's not fully formed anyways. The roots aren't totally formed, but you can see it's kind of through the bone, but it's not really moving anywhere. There's impacted canines on slide 59. And slide 60 is a definite case of transposition, because that canine wants to come up straight through the mandibular incisors. So that's an issue. And it even looks like it's resorbing the apex of that one tooth, which would be really bad. Okay, slide 61, acquired dental abnormalities. So attrition, abrasion, erosion, those are all acquired. So you're not born with those. Those are just things that happen from habit. So normal physiological wear resulting from normal function, that's attrition. We all get a little bit of that at some point, like through the years. You're born with mamelons, those little bumpy things, and then those go away pretty fast. That's a form of attrition. Abrasion, abnormal non-physical wear caused by foreign substances or excessive habits, and then erosion is usually chemical, not bacterial. So lemon, acid, things that are more acidic. And so here's some pictures of attrition. You can see just a really, and sometimes it's a little bit of everything. Maybe someone has GERD, and so they have more acid coming up out of their esophagus, but they also grind their teeth. So it can be, it can be a combination. Slide 63 is some more attrition, but see how it's kind of that cupping, that little bit of a cupping kind of, it almost also speaks to erosion as well. There's a little bit of like a concavity. Abrasion is up around, we looked at this already with some of our slides on in the perio, or no, caries, because it can be from, a lot of times they used to think, oh, it's like toothbrush abrasion, you brush your teeth too hard and you're wearing away at the gum line, but they also are understanding it has a lot more to do with the parafunctional activity and issues with biting and forces on the teeth. So here's erosion on the backs of the maxillary anterior teeth, maxillary incisors. That's one of the most common places to see like acid erosion, but you can also see wear facets and acid erosion on the molars as well. You can see it anywhere, but this is a common place behind the lingual surface of the maxillary incisors. And that's erosion could look like that, just more radiolucent because you've lost tooth structure. It's thinned out, so it's going to look more radiolucent. And then 67, non-tooth related miscellaneous. So we just have some random things. You've all know mandibular tori. One of these days, I'll take some intraoral images of my very impressive mandibular tori. So you guys can see like a major, it can be difficult to like place your x-ray right in between the tori because it's like you only have this much space and you can't turn it. You can't, go a little more contralateral to get a different angle because you're boxed in by the mandibular tori. But they will show up on x-rays as well. And then 69 torus. So there's you might not see it as easily on an X-ray, but the maxillary torus, certainly you'll see it clinically, intraorally for sure. And then the last one, we just barely got in, squeaked it all in, is a retained root tip. So you'll also see other abnormalities, like you might see the outline of the socket. Like if a tooth gets extracted, you might see that more radiopaque outline of the tooth. You can see retained root tips. There's actually lots of other funky things that we didn't even get to for abnormalities, but those are hitting the main ones. So good. Okay. So the other PowerPoint, the periapical abscess, I'll record it. I'll try to just record it in my office today. And so I can post both of those. And then next week I'll post the recording for it's the cone beam, talking about 3D imaging. And I think it also talks about just a little bit more about digital imaging too. So those are the content for that. Thank you guys for sticking with me. And I'll go in also and grade everybody's landmark exam, and then I'll upload the grades today. So you'll know your final grade in just a little bit.